Hello, everyone. Welcome to the Patient Safety Awareness Week. And today we have a lovely panel from all over the world. What we are looking at is to have a conversational chat on how we go about getting started with patient safety education in research. And it would be a roundtable. We would connect with our lovely team here. So let's probably have a round of introductions, and I would go by introducing myself. I'm Ashokka, an anesthesiologist from National University Hospital in Singapore, and here I am to help with coordinating this event. And my backgrounds are with simulation-based postgraduate and interprofessional education, crisis management, and obstetric regional anesthesia. And I also support the faculty development in health professions education. So let's invite Associate Professor Craig from Auckland, New Zealand to introduce himself, please. Thank you.
Hi, my name is Craig Webster. I'm an associate professor with the Center for Medical and Health Sciences Education and the Department of Anaesthesiology at the University of Auckland School of Medicine. So my interests really in health and safety and medical education stem from a sort of psychological human factors point of view, because my background is actually psychology. And I've done a lot of work around ergonomics and the redesign of healthcare work environments. And we published various work on that. And I've actually got some slides which I could share to just bring you up to speed with some of the latest stuff that we've been working on.
Yeah, we can
you see that okay?
Yeah, it's in slide sort of view.
Go back to the start. Okay. So I thought I'd start with this BJA paper that we wrote just last year, which kind of reviews 100 years of safety and anesthesia, because it was a centenary paper, and they wanted us to sort of look at the development of safety and anesthesia from the beginning of anesthesia in Britain. One of the things we emphasize in this paper is the development of Safety 1 and Safety 2. So Safety 1 is about linear systems. It came about in the early industrial developments in safety, manufacturing, and things like that. So it kind of assumes that things go in a sequence like this. And failure occurs from a malfunction in a linear causal sequence. So you find problems and you fix them, you report incidents, and you standardize processes to make them less error prone. And this is basically what we've been doing in healthcare for some time. It's useful and it's still common in healthcare today, but standardization is only quite limited in healthcare because people don't come in standard models and shapes, and neither do their diseases. So the degree to which you can standardize in healthcare is quite limited. And in complex socio-technical systems like operating rooms, this is particularly the case. A lot of standardization can occur here, but there's much more limitation around standardization than there is in other kinds of industries, including aviation, manufacturing, all those kinds of ones. So these are much more non-linear systems. You never know how long the process is going to take or how many steps are going to be involved. And it requires a lot of adjustment. So Safety 2 says that the focus is on things going right, not just eliminating accidents. And this often happens through skilled adaptation by people in the system. So the people in the system have to make continual adjustments to keep the system on the rails. And failure occurs from unexpected combinations of everyday performance variability. It's a terrible mouthful, but that's the definition of Safety 2, Safety 2 failure. And what that means is, I've tried to sort of diagramize that. Normal operating variability is this little red wiggly line, because patients come in all different shapes and sizes and require all different kinds of adjustments to their treatment. And the threshold for incidents and accidents is about there, around that wiggly line. But there's all these different background functions, and these are all the things like changes in supplies of equipment, changes in team members, changes in work domains, all kinds of things that happen in healthcare all the time that disrupt the normal operating variability. And you can get constructive and destructive interference between all these different functions. And when the normal operating variability constructively interferes with all these other background functions, it pushes it outside that acceptable envelope of considered to be acceptable practice, and you have an accident. Now, that's a very different idea of what an accident is compared to safety one, because safety one is about something's broken, let's fix it. Here, there's nothing actually broken. It's just variability has exceeded acceptable parameters. So if you think about that in terms of variability around a zero line, so zero line is when everything goes exactly as planned. When things go a little bit better than planned, they're on the green side of this curve. When they go more poorly than planned, they're on the red side. And really bad things are down this red tail. These are accidents down this end. So safety one can only really address this red tail. And we know that organizational headwinds push everything in that direction. What we want to do is actually access some of the data in the middle here, which is like self-report, observation rating scales, and push the distribution in the other direction. So we want to make things which go well go even better, so that whole distribution of outcomes shifts. And if you do both safety one and safety two together, you can get a synergistic effect because they're both entirely compatible. So that's the first paper. Perhaps I should stop talking. That's probably 5 minutes, right?
That was lovely, actually. Please carry
on. Just let me know when I should stop talking. So one of the things that some difficulties and milestones in my development is that as a researcher is that often I find that people still resort to blame when things go wrong in healthcare, and I find this unbelievable, really, because you know in psychology very well that blame doesn't help, and redesigning systems is way more important and way more reliable and way more sustainable. So pointing finger and blaming people doesn't help, but it's still often the first response from individuals and also management and healthcare organizations, which is not good. And we've seen some recent examples of that, even just in the last few years, despite the idea that we're supposed to be thinking about systems, not people, and not blame.
Thank you.
Yeah.
So, I mean, if we put the four of us together from these four parts of the world, I think we can talk an entire afternoon for that. So,
yes.
and it's 40 minutes of chats. So maybe, thank you, Greg. We will revisit on that. Can I invite Weiling from Singapore to introduce yourself and briefly share what you do? And thank you. Please.
Hi, good morning, everyone. My name is Weiling, and I'm serving as an assistant professor at the Department of Nursing at the National University of Singapore School of Medicine. So my research focus is mainly on patient safety and quality of care, with special interest in nursing workforce development and developing the interprofessional and intraprofessional teamwork and communication competency through innovative educational intervention, as well as another area of my research interest is on sepsis care. So I also serve as the program lead for the simulation-based team steps interprofessional education for our final year nursing and medical students. Yeah. So, being situated in a nursing training institution, right, a significant part of my patient safety education research focuses on, using simulation-based training to develop the interprofessional teamwork and education communication skills among pre-registration nursing and medical students. Because, traditionally, our students, they undergo pre-registration training in silo. So with really very limited opportunities for collaboration during their education. So in a way, when they are being thrown in, when they enter the workforce, they are being forced in a way to be able to effectively work collaboratively. So a large part of my patient safety research is focusing in this area. Yeah, using, traditionally we use conventional simulation, and, because of all the logistical challenges, we moved on to developing virtual simulation. And we face like challenges because of things like, when we develop a multi-user simulation software, we require, everyone to log in simultaneously at the same time. And also we have a very unequal cohort of nursing and medical students. So we moved on, to develop an AI-enabled virtual simulation software training program for our nursing students. Yeah, so basically this is like a nutshell of what my research is about. Yeah. Okay.
Thank you, Weiling. Anytime you walk into her center and you visit her team, I'll always feel illiterate. They are so far ahead, and the things that they show in terms of outcomes and how education is improving is phenomenal. Yeah, thank you, Weiling, for joining. Doug from the US, please.
Sure, and thanks for generating this conversation, Ashokka. It's great to be with everybody. Good morning, good evening, wherever you are globally. I'm Doug Paull. I'm an associate professor at Georgetown University, where I teach patient safety in the executive master's program in quality and safety leadership. I also work at the Accreditation Council for Graduate Medical Education as a field representative in the CLER program, Clinical Learning Environment Review program, with a heavy emphasis on patient safety. My background is a cardiothoracic surgeon, and I maintain I'm a certified healthcare simulation educator and also certified patient safety professional, and have a master's degree in patient safety. My three areas of research that I wanted to share on today's call revolve around, first, the integration of trainees in hospital, clinic, and medical center everyday patient safety practices. So I'll try to, I may not do it as well, but I'm going to try to share an article or two very quickly.
Doug and I meet in sessions in conferences where we do workshops together. Thank you.
Let's see if I'm sharing the...
Doug, what we see is the screen where we talk about questions and themes.
Yeah, I don't...
So I have the article on my side. Do you want me to put that from my end?
Please. It's the article from it's the article on resident involvement in patient safety and vet investigations. I'll stop sharing.
Errors upstream and downstream?
Nope, it's the other one.
The pursuing excellence.
Pursuing excellence, yep. Thanks.
Okay, so I got this and we share this. Yep, we have this here.
Thank you very much. And you can just, the title's probably enough. That's good. Thank you very much. So in this particular article and study, 16 healthcare organizations, and it was really a proof of concept. Can every single new resident and fellow in a healthcare organization be included as a chartered member on an RCA squared team? And the answer turned out to be yes, it can be done. And that's important in and of itself, because as a challenge or barrier, you often hear scheduling this or that. Once a program is committed and sets a goal, there are a number of ways, and the article goes into that, how they did that, not how we recommended doing it, how they achieved that. But more important, and wasn't expected, is we measured the quality of the RCAs with resident and fellow involvement. And we used a validated tool called the Strong String Assessment Tool. It looks at the strengths of the actions and other things. And Craig, from a human factor standpoint, you would enjoy that. But the bottom line is the RCA actually were better quality with resident and fellow involvement. So that was an important finding. Ashokka, you can stop sharing that.
Yeah,
thanks.
Sure. Thank you. So I think that's a lovely team who look from various aspects. I think Craig looks at the systems aspects of safety and the big picture of how they interact and make a difference at workplace. And the models which Craig shared, we could look at any setting. Every setting has chaos. And I remember, Doug, we had conversations about home visits and safety of aids which the caregivers provide, and how do we look at standards in that. I mean, that was a different topic in itself, but it was amazing because most of the events happen there. It's unsupervised. And Weiling's work actually stemmed from rapids and what we call as looking at clinical deteriorations and how we take longer to pick up. One of my areas of interest was to actually see with 10, 15 years of what we call as traditional simulation has not shown the same effects. And every time residents graduate, you see the same patterns of errors. And my personal interest was from actually in interprofessional settings when we threw the ones who we call exam smart, are the first ones to clear exams to be graduating as professional specialists, had appalling catastrophic events. And we had to think back on how the entire team didn't think the person was competent, but the exams brought them there. So that's what drew me into medical education.
So have you published that work about those kinds of failures?
Yes, we did the educational side of things, attributing to the failures. We had to sort the anesthesia exams. We added the simulation in the vivas, where we now look at how people actually act in the stations rather than speak in the stations, and we looked at it. But we could a lot of well, we are skipping there, but I would actually say the biggest difficulty for me is um, looking at these socio-political incidents in training and then try to find a system which can actually prevent that from happening. So when I work with the residency and educational teams, I struggle with this. It's a conversation in itself. Definitely, Craig. We will visit that. So can I, from each one of you, ask in your journey as educator with patient safety research, what do you see are the lessons learned? And we could look at the barriers and how we could improve. So maybe you could relate to what you developed and then look at this was a problem and this is what we changed. And people should look in this aspect as research. So can I check with maybe Weiling? How did you modify research?
Okay, yeah. So for mine, because we are situated in an educational institution, so definitely I think we had it easier than researchers who are doing patient safety education in the hospital, getting everyone to come together. So, we have moved, I wouldn't say we have moved past conventional or the traditional simulation. In fact, our students would still want to have this in-person simulation, to help them consolidate and reinforce their learning. But as I mentioned earlier, because of all the logistical challenges, we had to use virtual simulation. And we do get a range of facilitators who help us with simulation, and not everyone that acceptance or that IT savvy when it comes to virtual simulation. So we really had to get a lot of buy-ins, from the upper management and also among our own pool of facilitators as well, training them, giving them the confidence, and always being around to provide all the technical support. And at the same time, we collect evaluation feedback from the students and show them, how the students actually favored this pedagogy of learning. Yeah, so this is some of like the challenges we had, and we kind of like overcome, and we constantly collect feedback from the students and as well as the facilitators, and see how we can improve our program. Yeah.
Thank you, Eileen. I think most of us would agree in a good way that when the pandemic struck, we had to scramble for other forms of educational ways of getting people competent. And from Weiling's team and her center, we know that there was a big push into simulation in virtual interprofessional collaborations. People could not see each other. and it was an opportunity to actually develop the platform. So one thing I like about the work from her team is that when we threw people into physical simulation, especially with interprofessional differentials, people did not speak up, and we come from a Asian Confucianist backgrounds of bringing up, and in hierarchy setting in. So when virtual avatars were put on people, people actually very strongly participated in interprofessional setting. So they switched the model of having them virtually talk to each other. You can choose any mascot. It can be Iron Man as the physiotherapist. And then they went in to challenge and participate and comment, and then had the ones where they could actually have the face on and then physically there. So I was impressed because that's an important area we could explore. So do people actually speak if they're allowed to not have their face on? And how do they stand up to the event? Does that trigger anything, Craig, to you when we say that?
Yeah, I mean it's the positive side of the same phenomena that goes online when you have people attacking other people in a negative way, right? So, all that kind of social media harassment, you flipped it on its head and actually made the anonymity into a good thing, because people are able to communicate more forthrightly because of that. Interesting.
Yeah. And can I check with Doug? In your journey with all the educational aspects of research, um, what major lessons or modifications you had to do? I know you were a US Air Force veteran, and you're a cardiac surgeon, and you're an accreditation specialist. So you got all the ticks, and then from that lenses, would you be able to share something?
Yeah, maybe kind of inspiring your students to maintain that mindfulness or that open-mindedness towards the causes of patient safety events and the solutions. And I'll give you just one example. As we looked at timeouts and the universal protocol, because they're often looked at as the end-all be-all to prevent wrong site surgery. But in our organization, we were finding wrong site surgery in the operating room was rare, but wrong site procedures at the bedside were a tremendous issue or challenge for us. And furthermore, a wrong site thoracentesis, I don't need to tell anybody on this call what that implies. In fact, it's an often fatal event and has serious consequences for patients, their families, for the organization, and for the healthcare team that's involved in the events. So we looked at our very large RCA database. We use natural languaging processing to ferret out. And we looked at what we call errors upstream and errors downstream. That is, we looked at every case and said, these are the cases that had a perfect timeout, documented and get done. And yet they still had a wrong site procedure. And what we found, for example, an example of errors upstream were wrong prostatectomies, where because the error upstream could be with barcoding or mislabeling of a laboratory specimen done at an outside clinic. And so you can do a perfect timeout, but you're simply verifying wrong information. And that patient can undergo a prostatectomy, and then, of course, there's no cancer in the specimen. And furthermore, there's a patient that needs a prostatectomy, likely, and not to mention the complications that the patient that didn't have cancer was subjected to. So you can only imagine, and these were not an insignificant number of patients. We're talking about errors upstream or downstream, about an order of 1 out of 5 wrong site procedures. So that would not be caught by, downstream is a little interesting. It's spinal surgery. And I have to say, some states in the United States do not even look at wrong level surgery as an incorrect operation, which I find fascinating in and of itself. In our organization, we do look at that as wrong site surgery, as we would a wrong rib biopsy as wrong level is incorrect surgery. Well, that spine, you can do a perfect timeout, but due to patient positioning, radiographic factors, communication errors that occur in the middle of the operation, you can still operate on the wrong level. And so the solutions, as you asked, Ashokka, you asked for solutions in both cases. And one is a better barcoding upstream and adherence to barcoding and utilizing it, decreasing workarounds and training along those lines for the upstream errors. And for the downstream errors, a second timeout. It's a perfect example of when you're in the operation, our spinal surgeons will now confirm with another licensed provider that they're at the right level. They'll interact with the radiologist and they will confirm in the operating in real time with a digital or image that they're in the right spot. And if they think there may be a problem there, they have a conversation.
Thank you,
I'll
Doc.
stop there, but those are examples of where we've adapted.
Yeah, thank you. I mean, we do see people come with chest tubes on the other side, and then we used to question, and we used to like, how is it there's a chest tube from the ED this way? We didn't even know there was a protocol when people were hypotensive, they just put bilateral chest tube stat as part of research, and we were like blaming because of the awareness and systems not talking to each other. So, very interesting note on that. Maybe Craig, on your systems and the research dynamics which you changed, or what are the major shifts you did in research in education for patient safety?
We developed a thing called the Safer Sleep System, which we've shown reduces drug error in the operating room by 35%. And that involved barcoding, color coding, reorganization of the way the drugs are presented in the trolley and on the work surface and so on. And that's an order of improvement equivalent to the same magnitude as the WHO study. But it's reducing drug errors is actually quite hard. It's one of those multifactorial things that it's not easy to pin down one fault using root cause analysis, for example, because often the causal elements in every different event are very different. So you do have to take a multifactorial approach. That's the barcoding, the color coding, the repositioning, and all that kind of stuff. But I mean, I think we're only just beginning to realize that interprofessional interventions to improve teamwork really do have an impact on patient care. It's for decades, since the 70s, right? People have been talking about interprofessional education, and it's all a good idea, and everyone agrees it's a good idea. But the concrete evidence in terms of fewer dead patients, fewer injured patients, has been very hard to nail down, right? And if so in terms of getting the acceptance of interprofessional education by surgeons and other mainstream medical people, often there's skepticism around it, because you think, oh, it's all very nice, but I haven't seen the hard evidence on that. So we actually did may I show another slide? We actually did a review meta-analysis study just recently, which gives some very nice evidence that interprofessional education in clinical teams really does make a difference. This is the study here. So I'll skip the boring, but this is the Institute of Medicine that says, no definitive evidence for IPE in intermediate or final outcomes yet exists. That was back in 2015. That's actually what spurred us to do the study. We did a whole load of searching, because no one really labels interprofessional interventions as interprofessional interventions really in a systematic way. We ended up only including 20 papers. We had all kinds of procedures, all kinds of interventions, but most of them were around standardization of workflow, better teams, communicating with each other more often, etc. Consistent with that stuff about safety too, really, a lot of it. But here's the results. So all the ones on this side are benefiting the interprofessional learning group, as opposed to the conventional care group. This is 13,975 patients. We can see that you've got a 28% reduced risk of patient death in the group of interprofessional learning. That's a pretty big, substantial reduction, right? If you developed a new drug and it had this kind of efficacy, you'd be very, very excited. But this is the first evidence that I'm aware of this magnitude in terms of patient death. And we did the same thing on adverse events. And again, 23% reduction in adverse events in the IPL group. So interprofessional learning really does make a difference.
Nice, thank you. You actually opened up a box. I would see is most of jewelry, but I'm looking at how research and how we could prove this, and we could guide educators. So one of the themes we thought we could discuss about is when we are looking at research in patient safety education, what difficulties would you see when we attribute it? For example, where Weiling and myself, we come together and get people to learn interprofessional patient safety. So we bring about 400 odd students together in one place in various schedules. And when we do that, people are from various strata and development. So you might have a year 3 student, but they are pre-graduation in nursing, and a medical student is just entered clinical science. He is clueless. So the nursing colleagues would laugh at the students when they're doing hand hygiene. And the medicine side of things expects people to think broad differentials. What do you think is this? In the other systems, it's about competency and practice readiness to a direction for an action. So is this or this? Is it black and white? It's very clear to you. So the question would be, if you are looking at interprofessional patient safety research, I teased out a few of the difficulties that I have. From Craig's point, Craig, do you think, having shown this, a lot of people are going to go and prove this, right? So what difficulties do you see, or when you had to reject from 15,000 N to have about 13 articles, why would you reject those research? And what are people not doing right about patient safety education research in interprofessional setting?
I think in the medical literature, interprofessional education doesn't get a lot of mention, actually. I mean, it gets mentioned in the medical education literature, it gets mentioned in sort of peripheral healthcare literature, but in the surgical anesthesia journals, it often doesn't get called interprofessional education. So that one of the reasons we had to exclude so many papers in that review and cast our net so wide to find enough papers to do the meta-analysis was that often people talked about teamwork improvement strategies rather than interprofessional education. But actually what it was interprofessional education when you looked at what was going on in the intervention. So the term interprofessional education isn't consistently used, and that's part of the problem of doing those kinds of analyses. And I think there's also pretty unhelpful methodological division between people who like doing IPE work and often the core medical people who deliver healthcare. The people who like doing IPE work generally do qualitative work, and surgeons and anesthetists and other healthcare practitioners often do quantitative work. And so those things don't overlap. And so to find quantitative evidence of interprofessional initiatives isn't easy because, it's really hard to find. So I think we need to get the IPE people doing mixed methods or mixed methods research, and we need to get the medical people to start using the word interprofessional.
Excellent. So I think it was spot on in one of the difficulties I have when we get faculty development for a master's in education program. So people will throw in IPE, and I would ask them, are you doing quantitative, mixed method? Are you going in depth? We are talking about the feelings of people or what their reflections or are we just going to summarize some numbers? And on the other end, when you're sitting at editorial boards and you're reviewing papers, are they talking about self-reported satisfaction surveys, or are they going beyond Kirkpatrick 3 to say, at least in the simulation setting, do they look better, or eventually are they having less errors, deaths, and adverse events that you're talking about? Thank you. Doug, if I can ask from your setting, what do you think are the difficulties?
Oh, no, I will double down on the points you both made because I couldn't agree more. I think one big challenge with patient safety educational research, and you see this time and time again, is the limitation on the assessment or the evaluation to confidence level or satisfaction surveys, or even good culture surveys over longer periods of time. It's just that survey data is excellent and should be accumulated, but in and of itself, it's not adequate for vigorous scientific research. And I think you do need, and I like the idea of with interprofessional education of using things like the clinical teamwork scale and other validated tools to the unit of observation is the team. I mean, it just makes perfect sense. You're not evaluating individuals, because sometimes somebody makes a mistake, but somebody else on the team captures it. In fact, that's often the case in real life surgery. And there's plenty of studies that demonstrate that. So incorporating higher levels, even some of the ones that Craig mentioned, where you're looking at morbidity, mortality, O/E ratios. We've done team training in the operating room and demonstrated very similar data to your meta-analysis. I was fascinated by your meta-analysis because the improvement overall was about 20%. And you're right, if you had a drug that did that, improve the O/E ratio, and that was a step wedge study of over 200 medical centers in the Veterans Health Administration, and literally hundreds and hundreds of teams that underwent training for doing the timeout, using a checklist, debriefing the case, and then doing additional quality improvement initiatives in the ICU. But the other issue that we haven't brought up is, and especially when it comes to team training, teamwork, is recurrent training. We've got data that demonstrates, just like many other skills, the structured communication for speaking up, as you mentioned earlier, Ashokka, these types of things deteriorate over time. And oftentimes you'll see research studies where they've done one thing and then they measure it. And oftentimes they measure the survey data right after the training. I'm not sure what that even shows, really, when you see it. I mean, a PowerPoint, maybe a role play or a simulation, and then we repeat the same survey. I don't get it. But the bottom line is, I think the way that you've all described this evening is a path forward in terms of patient safety, education, research.
Thank you, Doug. Can I check two aspects from there? One is about Weiling's technology in IPE. So Weiling, when you had to design, I think, modern mixed reality or virtual reality to improve patient safety education, what difficulties do you see as a researcher to put this together? And when we write, you take up at least 2 to 3 hits to get published, and how difficult it is now to declare this to get a good standing.
Okay, so I think it's, when you design a program, right, it's really a team effort, like getting in, the medical, the nursing, and even the computing engineers, to come together to design the program. And I think, probably, like really like one of the challenge or difficulties that we face, it is really about measuring the long-term outcome or the retention, because I think like what we have done quite successfully, it is really to measure, like what Doug has mentioned, like in achieving their learning objective. But whether or not, when students, go out into the clinical or even the long-term outcome, their impact in real clinical setting, right, is something that we haven't really measured, and it's quite difficult, for us to really track, students prospectively long-term. So I think this is really an area where we really have to work on. Yeah.
Thank you, Weiling. One aspect I can share is that we mostly look at undergrad education when we are looking at structuring IPE to the detail that we talk about today. And we don't really see how they are actual practicing professionals as a specialty, like when they are in post-graduation, or even so when they're finished. So most would end that they were reported to be better interns, but they don't really necessarily single-handedly manage a case. They're basically reviewing and reporting at that level. But to make meaningful impact on outcomes, error prevention is there. So one of the inputs was about looking at longitudinal outcomes measurement from patient safety interventions, and that's tough, I guess. So
Yeah, it's hard.
great.
Yeah, I think that those two things are both hard. I mean, translation from learning in a simulator to clinical practice is hard to demonstrate, but also the longitudinal data collection is very hard as well. But I also think that, again, it comes back to a mislabeling or misconceptualization. I mean, the WHO Surgical Safety Checklist Study was an interprofessional initiative, but the word interprofessional does not appear anywhere in that paper.
Oh,
Right, so that's an IPL initiative. Yeah, that you've got a checklist being used with the whole surgical team. That's in professional learning right there, but they didn't call it that.
excellent, spot on. Nice. So in the last 5 minutes or so, I'm going to shift towards what directions would you want to give for young researchers who are going to look at these inspiring, aspiring aspects we have discussed and see how they can make meaningful research. And if you had to put your money on maybe 3 areas, what would you suggest? Can I ask Doug, please?
Yeah, I mean, I've thought about this, and maybe it's just because I'm getting old. But I would encourage up and coming patient safety education researchers to reflect a moment on and consider their own patient safety education needs wherever they are in their journey. So it may be certification, CPPS from the IHI, Institute for Healthcare Improvement. And it's not the certification that means is as important as the learning that would be required to achieve that certification. Or maybe others, it is a degree program. Increasingly, these are available online, hybrid. They scale and scope very nicely, so you can continue maintaining your work and get this and work on this additional knowledge. I think any time that you can bring get a deeper level of understanding, for example, Weiling and Craig have this deeper understand, and Ashokka, you have a deeper understanding of communication failures and challenges, the human factors approach, a systems approach. That deeper understanding will serve them well, regardless what the research. Now, here's the other bullet point I wanted to make, and this comes from years and having trained dozens of patient safety officers in this country. And their thesis and their capstones. They often in their research activities try to boil the ocean in the patient safety world. It's just not focus. So focus and focus again. And what's amazing about that is if you develop an area that you're enthusiastic about, that you're the expert on it, whether it's regionally or otherwise, and build on that, you will develop just like has been shared tonight, these general themes come from a very intense research in unique areas that all four of us have that are different, and and then the shared themes come in common. But that's what would be my advice. So invest in your own patient safety education and focus like a laser beam on a patient safety educational research topic.
Thank you. That was lovely. May I invite Weiling, please?
I totally concur with what Doug has mentioned. And I would say, one advice, I mean, I'm quite a novice, like researcher as well, but one advice I would give is, married to the problem and not the solution. Yeah, so, like stay focused with the problem and then like constantly trying to address the problem. So for me, like my own, like probably like the direction I mentioned earlier on, we moved from, like conventional simulation to virtual simulation, and now also using, some sort of harnessing AI into simulation. So I think, for us, it's really finding the right blend of simulation learning, because I don't think, any of it alone it is superior, but it's more of, finding the right blend of simulation learning to address the problem that we are trying to solve. Yeah, so that's from me. Thank you.
Weiling, maybe Craig, please.
Yeah, look, I agree with everything Doug and Weiling has said. I mean, I think it is about taking the bigger picture, but then applying it to a particular problem. And so, you know, you need both. You need that sort of wider, deeper understanding of the of concepts of safety and the tools available to help you with it. But you have to, at the end of the day, apply it to a particular problem, which you have to focus on. So it's not about being blinded by the latest fancy technology, or you know, always doing a root cause analysis, for example, or you know, there's lots of other tools out there too, and some of them might be better than that. Or you know, AI is very new and it looks very helpful for lots of things, but again, it comes with limitations, and you know, it's not a perfect tool. So you know, we shouldn't get hooked into the sort of gee whiz aspect of the latest thing. We should start with the problem and then try to develop a deeper understanding of how we solve it.
Nice. So I think for me, it would be about looking at the present literature in the last 2 to 3 years and uprise which would be the direction to go, and let not get turned down by being labeled as quality improvement work. And most of the times the review comments would be lack of external validity, cannot be generalized. So it's good to compare various settings and contexts across continents and collaborate through international settings. And when platforms are used, it is important to go to hybrid learning avenues, not just a mannequin, not just virtuality, mix them together if you are using in education. So that will sort a lot of generalization issues with multi-professional setting. So if I looked at the AHRQ, the Agency for Healthcare Research Quality's 2024 patient safety research opportunities, I think it states the following. I can share this bit. So what it talks about is these are the possible research avenues that we have, but what looked pretty interesting for me is patient safety across continuum, and then the technology and impact. We mentioned about AI, it's another session in itself, and optimizing research methodology and enhancing measurement effectiveness. So I guess that gave most of the listeners and us a chance to interact from the various contexts. I really love today's conversation. Any closing remarks from Doug, please? Anything you want to share?
No, just thank you, Ashokka, for the opportunity to learn from Craig, Weiling, and yourself, and to address your larger audience. Been a lot of fun. Thank you.
Thank you. It was an initiative from the Patient Safety AME SIG, and it's part of the Patient Safety Week in March. And this would initiate teams, have chats offline. We would share excerpts from this. Craig, you have any summaries or thoughts or chats about this?
Yeah, look, it's been a really interesting conversation, and I've really enjoyed hearing about Weiling and Douglas's work. So, I mean, I'd really like a copy of all the papers we've talked about today. Your upstream and downstream analysis paper, Douglas, sounds particularly interesting to me. So, yeah, can we share those?
Yes, we would. So we would provide links, and we basically having a team of collaborators here, and that's how we would start conversations. And Weiling, anything from your end?
Nothing much. Yeah, so really, a very engaging and interesting conversation this morning, learning from Doug, Craig, and Ashokka yourself. Yeah, so thank you for this opportunity to be around. Yeah, thank you.
Yeah, so wishing everyone safe practice in their settings, and from the lessons learned, it was a lovely conversation. And thank you very much. Thank you for the time.
Thank you, Ashokka. Bye-bye.
So